Good afternoon, everyone. Welcome to the first of our AIM and Melanoma's symposiums. We have people who will be joining us from all across the country. This has become an annual tradition for AIM and Melanoma, started by Doctors Farma and Olszanski. So we want to thank them for that. If you'll wait just a few more seconds, we want to give the hundreds of people who signed up for today's webinar an opportunity to join us, and then we'll get started. So give me about 10 or 15 more seconds and then we'll get started. Okay. Welcome again to everyone. I'm Ann Garst-Taylor. I'm the Director of Community Engagement for AIM at Melanoma. We want to welcome you to our discussion of the future of melanoma treatment in 2024. As I said, this has become an annual tradition for AIM at Melanoma, and certainly one of the most highly anticipated webinars that we put out during the course of the year. Today it will be hosted by Dr. Olszanski and Farma, who are the co-directors of Fox Chase Cancer Center Melanoma and Skin Cancer Program. We know that there will be lots and lots of questions for them at the end of their discussion, and so we want to tell you how to get those questions to our panelists. If you are joining us via Zoom, then if you look at the bottom of the screen, you will see a tab that says Q&A. We ask you to put your questions in there for them rather than putting them in the chat, because we don't want them to get lost among all the different things that people are talking about. If you are joining us via via Facebook or YouTube, there is a comment feature there. You can put those questions in there, and then we will move them over to the Q&A tab for our panelists. And with that, I'm going to pass the baton to Drs. Farma and Olszanski and let them tell us all about the future of melanoma.
Great, Ann. Thank you so much. So, one, Happy New Year, everyone, and really such kind words. And we love partnering with AIM at Melanoma and doing these symposiums. I'm Dr. Jeffrey Farma, so I'm a surgical oncologist and the surgical director of the Melanoma and Cutaneous Program at Fox Chase. And my partner is
Tony Olszanski. I'm one of the medical oncologists, and I work very closely with Dr. Farma and really the whole team here at Fox Chase in trying to help patients with melanoma.
And as Tony said, we work together, really talk multiple times a week. We have a multidisciplinary tumor board and really have built up a team here at Fox Chase that is really so exciting. And one of the reasons why we're so excited to be talking today and about new therapies on the horizon is the world of melanoma has been changing so dramatically that it blows our mind sometimes to even think of where we are, but more importantly, where we're going. And so we're really excited to answer questions today and talk about the changes that we've seen actively in clinic, what we're doing, and then what we see coming down the pipeline actually in the very, very near future. So with that, Tony, why don't I talk about a case that kind of came our way that, and we'll talk very briefly about the situation and kind of how we think about it, and also how we changed how we thought about things. So a patient came to me with a very large, what I would call mass, not even a skin lesion, but a mass on her arm. And it was sticking out. We usually talk about millimeters in melanoma. This was sticking out at least a centimeter grossly. So I didn't need a microscope to measure how deep it was. We could actually measure with a caliper of her skin. And the lesion was about, this big on her arm. And when she came into me, I felt a lymph node under the armpit. So, and I did a fine needle aspirate of that in the office. And we have the luxury of excellent cytopathologists here at Fox Chase. And 20 minutes later, they called me and told me it was melanoma. So at that point, Tony, what do you think? So we know that it's the melanoma spread to the lymph nodes and has palpable disease. This is not microscopic. This is macroscopic disease. What do you think the best thing right now to work from a workup standpoint? And then how do we think of these types of patients, and how have we changed how we think about these patients?
I think what strikes me so much, Jeff, is how we used to think about these patients. I think any one of these patients, 5 or more years ago, would maybe have gone directly to surgery, no questions asked. It would be the right thing to do. We would do a fairly large surgery to try to get this mass out of the arm. We would then get all the lymph nodes out of the axilla area, the armpit area, to try to make this patient as disease-free as possible, and then probably give immunotherapy at that point in time, given the high risk of recurrence. But there is something that has happened relatively recently, and we've really been captivated by it over the course of the last couple of years, and that's what we call neoadjuvant therapy. So before I really go into maybe some of the trials about why we do neoadjuvant therapy, and I think it does have a lot of great rationale, maybe I could toss it back to you, Jeff, to explain the concept of what adjuvant and neoadjuvant might actually mean.
Sure. So historically for melanoma, for years and years, and I totally agree, this was a surgical patient up to just a couple of years ago where I wouldn't have even sent her your way. I would have just said, I would have gotten a PET scan to make sure there's no evidence of metastatic disease, and they did not have any of that. But I would have just operated. And we've really changed the paradigm, and this is where having a team is so important. So we have shown in the last few years that we know that melanoma is exceedingly immunologic. And we know that having the presence of melanoma cells in the body when we give immunotherapy can really ramp up the response of the immunotherapy. And multiple studies have really clinical trials that have shown that when we actually consider neoadjuvant, we're seeing just unbelievable responses. So when we go back to adjuvant, so when I operate, if we do a resect a melanoma and then let's say a sentinel node is positive, or there's lymph nodes that are positive, and I've done upfront surgery, then when we give therapy afterwards, if it's immunotherapy or targeted therapy with BRAF MEK inhibitors or other therapy, that's what we call really in the adjuvant setting, to decrease the chance of this melanoma coming back when we don't see disease. Neoadjuvant, and we've used this for many other types of cancer as well, but the idea is to give the therapy before surgery in hopes of actually in real time seeing the response as we give it. Are the tumors shrinking? Is the PET scan getting less bright? Are lesions going away? Or you know, God forbid, also are lesions growing? Where we give neoadjuvant therapy before treatment, reassess, and then consider operating. And so that's really the difference. And so we had talked about this patient, Tony, and we both were in agreement that we should consider neoadjuvant therapy.
Yeah, we did. And that's because of some of the emerging data. We've now known for quite a while that using immunotherapy upfront with patients with metastatic disease that has traveled beyond the regional basin of the lymph nodes, can be very, very meaningful for their survival and surviving melanoma. Quite honestly, possibly making go away. And maybe the poster child for this these days is President Jimmy Carter, who was diagnosed with metastatic melanoma, even to the brain, when he was like 88 or 89 years old. I forget the exact age. And now he's up in his upper 90s, celebrating birthdays and outliving just about everybody else, doing a great job. He potentially has been completely cured of his melanoma and is likely not to die of that disease. So we took what we knew in that setting and we're starting to apply it now in this neoadjuvant space before surgery. And there's a rationale for that. If we take the tumor out of a patient, and we give immunotherapy, it's hard to educate the immune system on what to attack. It's just sort of sitting there wondering what it should be going after, and we can see certainly side effects from our therapy. On the other hand, if we give therapy before the tumor's actually been taken out of the body, it's much more likely that the immune system might be able to identify the tumor as something that isn't supposed to be there and start mounting its attack. And so we started using some of the immunotherapy that we were using in the metastatic setting, like ipilimumab and nivolumab. And what really struck us, I think, across everybody who works in this field, is when we took tumors out of patients, about 50% of the time, we would see what we determined as a complete pathologic response, meaning that we could not find any live or viable tumor tissue in the surgical sample. And that was really wonderful. We've done studies now with Ipi-Nivo. We've done study with another medication combination called Opdualag, which is nivolumab and relatlimab. But probably the most impressive study that's been run to date is one which is all about single agent pembrolizumab. It's the ECOG 1801 study. And in that trial, they actually took patients and they split them into two groups. One was a neoadjuvant group and one was an adjuvant group. They took those patients and they gave 3 doses of pembrolizumab before surgery, and then did surgery, and then continued pembrolizumab so they would complete a whole year. Or in the other group, they did upfront surgery, which has always been the standard of care, and then they just did pembrolizumab for a year. And in that study, it was really pretty clear relapse-free survival was significantly better in the patients who got this neoadjuvant approach. And so that's what we ended up doing with our patient. We gave her immunotherapy, and we started seeing responses to her lesion on her arm within the first 3 weeks. I remember that very, very vividly. When she first came to me right after seeing you, she had that very large tumor on her arm, which was really quite firm and quite ugly. And 3 weeks later, although the characteristics visually didn't change much, it was already getting soft. And we gave her maybe 3 doses before she came back to see you.
Yeah, and it was amazing. And it led to questions, I think, in our group. And this was early on in our neoadjuvant experience. But by the time I took her to surgery, which again was very quickly, these medicines don't affect surgical healing. And so we don't really have to we have to always be careful, but there's not a risk of stopping the medication and waiting. In some medications or chemotherapies, we have to wait 6 or 8 weeks to surgery. We don't have to do that with the immunotherapies. But by the time that I took her to surgery, instead of being a centimeter raised off of her skin, it was actually flush with the skin. It was amazing. And the lymph node that we could feel was not palpable anymore. And I ended up doing the same operation that I would have done historically beforehand afterwards. So because she had palpable disease, I ended up taking out all of her lymph nodes in her armpit. I usually quote patients about a 20% chance of having lymphedema after that operation. And then she had a big lesion, so we resected it with 2-centimeter margins around. And as Dr. Olszanski said, when we sent it to the pathology lab, there was no viable melanoma. Everything was dead, which is amazing.
It is amazing. I think it's important to point out, though, Jeff, we're talking about really a patient who did really exceedingly well. That, unfortunately, is not every patient, right? We can't count on immunotherapy to cure all patients or get rid of the tumor for all patients. And that's why I think it's so important that medical oncologists like myself and surgical oncologists like yourself remain so in communication, because we need to know exactly when to pull that trigger. If the immunotherapy doesn't look like it's doing anything, I really want to get that patient back to you as quickly as possible.
Exactly, because we know that surgery is potentially curable. Surgery still cures more patients with melanoma than any other modality we have, and we want to be able to offer that to patients. So I agree that communication and crosstalk and really having a team that addresses this is so important. And some of the questions that I think came up in this case, and we can talk about some of this, is, so one, did I have to resect with it as wide margins? And we're looking at it when we talk about, and we'll talk a little bit about some clinical trials, but did I really need to do that, or did I just need to remove the lesion? I think still up for debate, really. Did I need to take out all the lymph nodes, or could I have selectively just taken out the lymph node that we knew had melanoma and not the other lymph nodes? And so these are things that I think really we've already started changing practices and are looking at in clinical trials and talking about at all of our tumor boards are really about, I do believe that we're going to see in some aspects de-escalation of care for melanoma. In some aspects, escalation of care, because I think that I'm going to have to operate actually on more patients that either sometimes recur or we're removing metastatic sites of disease that we wouldn't have in the past because they've responded and have one lesion. So there's this kind of balance, but between what we're doing and seeing and in the melanoma space, that's really exciting to all of us. So
it really is. And I think that excitement is now not only changing our setting in this disease setting where we're thinking about surgery, but it's also influenced really therapies before we even think about surgery. Now we're talking about some vaccinations that we have for some patients. We're talking about in the metastatic setting, we're talking about using the immune system as an adaptive approach. We're adapting the immune system for a patient to go after different cells. And so one of the ones that's sort of coming up, the FDA is going to vote on whether or not it's going to be a legitimate therapy. And they have up until February 24th of this year to make that decision. And we expect that based on by February 24th, 2024, the FDA will either approve or not approve what we have now known as tumor infiltrating lymphocyte therapy. Dr. Farma, that actually started in a surgical unit, the whole idea of TIL. So could you bring us up to date on that a little bit?
Yeah, sure. So for years and years, and this is really Steven Rosenberg was really one of the thought leaders in this and really drove this process that we know that your own white cells in your body are attracted to melanoma. And for years, they were doing clinical trials and still are at the National Cancer Institute in Bethesda and some other institutions about harvesting the melanoma, growing up those TIL or tumor infiltrating lymphocytes, basically cancer-seeking white cells that your body makes into billions of cells, and then giving those cells that we know have effect on the melanoma back to patients. And this is in the metastatic setting, whereby you basically ablate or with either chemotherapy or radiation, your own innate immune system, so you don't have any white cells. And then we give back to you only these white cells that we know are attracted to your melanoma. And so we were part of a clinical trial here at Fox Chase doing this. And we're really excited because this opens another line of therapy more broadly in the world, really, to allow us to treat patients with advanced melanoma. And so, Tony, who do you think would be like candidates for this therapy if it is approved?
Yeah, so I think that it's all about patient selection. These patients, they need to have an identifiable tumor because we're actually needing to resect that tumor, which is another reason why you and I and people like us need to be so much in tune with what's going on with our patients, because we have to have a patient who can have that tumor resected, and then that tumor is then sent off to a lab where they take out the lymphocytes from the tumor, which are educated. They treat them with interleukin-2, and then we usually bring those patients back 6 to 12 weeks later after the therapy is sort of ready to go, and we give that therapy back with interleukin. But there's a lot of caveats. Patients have to undergo surgery in order to make this product. It does take some time before the product is ready, so there's a waiting game before you can actually get the product, and that can be challenging to wait that long. And then finally, getting the product itself does require getting some chemotherapy. We use the chemotherapy to basically make room in the bone marrow to let the new white blood cells come back in and repopulate. And it also includes interleukin-2. And interleukin-2 has a pretty strong history of being pretty toxic, even though it can be helpful. And so we do have to establish all of that with the patient. So I think that while it's an exciting therapy, we've seen response rates, somewhere around 50% in some patients, which is great. Overall response rate compared to ipilimumab, for example, in a relatively smaller trial was 50% compared to 20%. So it really outperformed ipilimumab in that study. And I think that that's what we have to look for, but it's going to be for a segment of the population.
Yeah. Again, just to highlight, this is the partnership between this team approach, because again, we need to harvest melanoma cells surgically to be able to give this therapy. So the surgeon's still quite involved in this process and the decision-making and the team. We do have multiple questions, Tony, but I'm going to ask you, there's a couple of new therapies on the horizon that maybe we can just talk about. So we are all very familiar with messenger RNA vaccines after the pandemic. Can you talk a little bit about vaccines and melanoma? We've been talking about vaccines in melanoma since I was in medical school, I think, or maybe residency. And they really never really came into the forefront. There's been many clinical trials, really, that very few that have shown any benefit. Is this going to be the same thing, or what are we looking at this year?
So I really don't think this is the same thing. This is another exciting avenue when it comes to the treatment of melanoma, but maybe also some other tumors. There's been some data even out in things like pancreatic cancer, which is actually really wonderful to see that. So yes, COVID sort of brought to the reality the power of what we call messenger RNA vaccinations. We have not always had the ability to use messenger RNA vaccinations because of three basic issues. RNA isn't usually very stable. It's difficult to keep it stable. It didn't have a very good delivery method. We weren't able to get it into cells very easily. And then it also had what we called immunogenicity. It would cause basically allergic reactions in some patients. And we had to get over those. But really over the last decade, the science has really rocketed and really solved all of those big problems. And so messenger RNA vaccinations became a reality, of course, with the COVID pandemic, setting records all around the world for the fastest vaccine that ever come to market to actually protect people. And by the numbers, if you look at me talking as a doctor, it's had a fabulous and literally world-saving effect in some respects. So we're now bringing this technology into melanoma. And basically, what we're doing with these melanoma vaccines using this messenger RNA is it's a very personalized approach. So again, it's a combination of the surgical oncologist and the medical oncologist, where the surgical oncologist will take the tumor out and will be sending that tumor off to get it looked at. And we talk a little bit about antigens or peptides, proteins that are on that melanoma that are patient specific. If I'm going to get treated for some disease I have, I want it to be specific to my body. That's probably ultimately personalized care. And that's what we're really talking about here. The vaccines that are made are personal vaccines. They're not for somebody else's melanoma in this situation with some of the vaccines data that I've seen, but rather from their melanoma. The vaccination is made and then given back to the patient. And usually then we're also using these immunotherapies like nivolumab, like pembrolizumab, which have already shown that they're really, really beneficial. And we're giving this to patients. And we've already seen a very, very significant benefit in patients receiving this. 44% risk reduction in the risk of disease progression after these vaccinations with immunotherapy compared to immunotherapy alone. This is shattering news because we've never seen numbers quite like this before in a setting of early stage melanoma.
Yeah, completely exciting. And so I totally agree with you that I think this is something that we're really looking forward to see this pan out in. I think there's a phase 3 trial that's ongoing currently. And so we'll really be excited about that. Tony, can you talk to maybe a little bit, and I'll comment about one of the clinical trials we're part of here at Fox Chase from a surgical standpoint, and then maybe we'll just a brief overview of some of the interesting clinical trials we have that are ongoing, and then we'll transition into some questions. So we are a site of what's called, there's an international MELMAR-T trial. So this is not as exciting as immunotherapy or vaccines, but for primary melanoma, so this is the vast majority of patients that come into us don't need any of these things, thankfully. But we still resect either 1 centimeter or 2 centimeter based on how thick the melanoma is. And this international collaborative is looking to enroll about 3,000 patients to see if, again, de-escalation of care, that maybe we really don't need to take 2 centimeter margins around the tumor. The problem with the 2 centimeters is a lot of times that could be the difference between closing the skin up on its own versus a skin graft, or leading to increased risk of wound complications. So we don't know the answer to this trial, but we have a lot of patients that we've enrolled in this trial. And I'm personally very interested because I don't want patients to get wound infections or their wounds to open up or have big scars or to go home with. And so I do think this is an exciting trial that we're happy to accrue to. Tony, you want to talk about we have a homegrown trial and then some other clinical trials briefly, and then we'll go to some questions.
Yeah, so we do have a homegrown trial. It's in the neoadjuvant setting again, where we are giving ipi/nivo, and we're also giving a different drug called Caraxin. And I'm just going to very briefly describe what we think this drug might be doing. Where if you've ever seen the movie Independence Day, there's a scene in that movie where there's a spaceship and nobody can shoot the spaceship because it's got a force field around it. And then somebody sneezes and the guy thinks, hey, I can give it a virus. I can decrease its defenses by giving it a virus. And so Caraxin is sort of working by getting into the melanoma and making it look like the melanoma actually has a virus. That's how Caraxin works. And when the body sees a virus, it attacks it. And so in effect, Caraxin is trying to give the melanoma what looks like a virus. It's not actually giving the melanoma a virus. And then it's allowing the immune system, immunotherapy with the immune system to attack that melanoma. So that's one of our homegrown trials here. It is in the neoadjuvant setting. We've been accruing to it really quite well. We're pretty excited about that trial, and hopefully it'll be meaningful. We also have what's called it's a newer therapy. It's called theranostics. It's based with radiation therapy. So we can now take particles that are going after a certain part of the melanoma, and we can tag it with radiation therapy, and we can infuse this into patients. We've done this with some other tumors already, but we infuse it, that marker attacks the melanoma, sticks on the melanoma, and then the radiation therapy is right there, and it starts radiating the melanoma right where it is. So it's sort of directed radiation therapy, no matter where the melanoma might be in the body. So that's the theranostics approach. And the last trial I'll talk about very quickly is something called adoptive T-cell therapy. So we talked about tumor infiltrating lymphocyte therapy. We're now taking lymphocytes out of patients. We're genetically modifying those lymphocytes to teach them about melanoma. And in one trial that we have, it's looking for another peptide or antigen or protein called PRAME. The preferentially associated antigen in melanoma is what PRAME stands for. And if it goes after this peptide, we're seeing some reports that responses are very, very high. So those three trials we're running here right now, looking at different ways of importing immunotherapy into patients.
Great. Again, you can see our passion for melanoma, and really, we love the fact that what we are seeing now in terms of responses when we both started, we couldn't even dream of. And it's just unbelievable. And thanks to AIM and everyone who's doing research for melanoma. So we'll take some of these questions. If we don't get to everyone's questions, one, we apologize. We only have so much time. AIM has a physician assistant on their website that you can contact that can assist with some of the questions if we don't get to it. So one question, Tony, is ipi/nivo the first-line treatment for metastatic melanoma that is spread elsewhere in the body, so metastatic, specifically to the liver, and do we see responses in the liver with ipi/nivo?
And so the short answer is absolutely, we do see responses. Now, not everybody responds, right? Not all patients benefit from immunotherapy. That's first and foremost something important to understand. But for patients who do benefit, we can see responses regardless of where the tumor is, including some of those areas which have been notoriously difficult to treat, like the brain or like the liver, for example. And so absolutely, immunotherapy can go after those areas.
Yeah, 100%. We see that all the time. So totally agree with you. Can you address the benefit? So using neoadjuvant therapy combined with targeted radiation therapy for a synergistic effect, sometimes also known as an abscopal effect. Do we utilize that in practice? I would personally say we've entertained it and we've treated some patients with this, but it's not something that we routinely do. Tony, what do you think?
I agree with you. Yeah, it's something we talk a lot about because there's been some intriguing insights that we've learned with radiation therapy. But unfortunately, a lot of the trials that have been looking at this both prospectively and retrospectively haven't really shown a synergism or an additive effect yet between radiation therapy and immunotherapy that is really, really helpful. So we still have work to do there.
Yeah. I won't get into all the logistics, but a patient's asking, they had 2 brain lesions treated with or on Opdivo, had Gamma knife and then surgery. if God forbid something comes back to the brain, is there a benefit of neoadjuvant therapy prior to treating it? Or the brain lesions are, definitely get us worried when we see these. But what are your thoughts on neoadjuvant therapy for brain lesions, or is it really neoadjuvant, or yeah?
Yeah, is it really neoadjuvant? I think that's a really good point, because if a patient already has metastatic disease and has been treated, we wouldn't really call it neoadjuvant. I do think that there's always some hope there, though, that implying immunotherapy again can garner new responses. So in patients who have had immunotherapy and have had a good response, and then unfortunately, maybe at some point in time had disease come back, we have seen some of those patients respond again to immunotherapy. But I also want to put a plug in here that, we're making strides with radiation therapy, especially in the brain as well. And we have cyberknife technology. We use surgery, not uncommonly, if there's a lesion in the brain. And it always amazes me, Dr. Farma, how patients tolerate brain surgery when we have a tumor in the brain. They come back to me, days later, and they're completely looking healthy.
Yeah, also amazing that we have a handful of patients that we've had with brain metastasis that were treated that are now 5 years out, that we've actually stopped immunotherapy on. So that in itself is just unbelievable.
Yeah, we wouldn't have had that opportunity just a few years ago.
Right.
Let me throw you a question, because
Sure.
one of them is around TIL therapy here. And the participant is asking, with these TILs, can we use an old tumor block, or do we need fresh tumor tissue?
Yeah, for this, you really need fresh tumor. So we would tend to, as surgeons, look at where the disease is in the body and determine what would be the most, everything's a risk-benefit profile that we do, but what is the safest lesion to remove? And that can include an invasive procedure, even a lung resection or liver resection or lymph nodes or a abdominal resection. But wherever we think is the safest location that we can harvest tumor, we would do that. But for adoptive T-cell therapy, you need fresh tissue. We actually take a segment of the tumor in the operating room and put it in media in a sterile condition, so that goes right to the company so they can start growing it. So it is a process and has to be harvested. They can't use old slides for that.
I'm going to pose one question here, which I think is really quite amazing. It's a wonderful story. The questionnaire writes, I was part of a clinical trial, and at first I'm going to stop and say thank you, because we don't actually learn anything unless people are willing to be part of a clinical trial. This is not becoming part of a trial to be a guinea pig. This is a part of becoming part of history and helping us learn how to move the field forward. And so I myself am highly vested in clinical trials, because I think it's the only way that we actually move our feet forward towards getting closer and closer to curing patients and making them tumor-free. So thank you first and foremost for being part of a clinical trial. You go on to say that the tumor was in your lung and was removed and taken from the surgery room and taken to the lab, mixed with your red blood cells, probably white blood cells. You've received 8 vaccines made specifically personalized, again, for you. And then you received 31 months of Keytruda. You're asking a really intriguing question. How is it to determine which method, the vaccine or the Keytruda, remove the remaining melanoma spots inside my body? And I'm looking at this saying, oh, this is a wonderful story. You have been so blessed in many respects. And yes, I'm a scientist. I want to know the answer as much as you do, but I don't care because you're doing well. So blessed that we have these opportunities. Jeff, what's your take on that?
Yeah, I agree. I think it's impossible for us to know, but that is a wonderful story, and why we do what we do, to hear stories like this. So it's amazing. We're a little over, but why don't we take one more question, and then we'll and then the other questions we can answer offline if needed. How about this one, Tony? If you have to stop ipi-nivo, so as much as we love immunotherapy, you give it all the time. You've given it to as many people for as long as anyone else really in the country. But sometimes there's reactions to it, and if you have to stop it, Is it still possible to have a durable response and cure even if you didn't get the full regimen that you were anticipating?
Yeah, and so there's a couple of things that we found. It's so intriguing, right? Because nobody wants a side effect, a toxic effect, an adverse reaction to a drug. We don't want to see that, and patients certainly don't want to experience it. However, we also have to recognize that sometimes when we give drugs and we see things, even when we don't want them, we can learn from that. And one of the things we've learned from adverse events from immunotherapy is that we are engaging the immunotherapy, the immune system, excuse me, and it's doing something. It might not be what we want it to do, but it's doing something. We have recognized now that there is a strong correlation between patients having an adverse reaction, something that we wouldn't necessarily want to see, and a good outcome. And so patients who have good outcomes are also more likely to have had an adverse reaction. Now, that doesn't mean that you've had to have an adverse reaction to have a good outcome, but to have one can maybe help predict having a good outcome. And so we do see that sometimes even patients who get only 1 or 2 doses and then unfortunately can't tolerate any more of the drug can have very durable responses. And I will also go on to say that that hasn't stopped us from trying again if we absolutely need to. Because at the end of the day, I have to worry about possibly causing a recurrent adverse event or allowing the melanoma to potentially take the life of the patient. And I think that's a pretty easy thing to juggle. Most patients are going to say, no, I'm going to go ahead and see if I can tolerate the therapy one more time. And surprisingly, and again, thankfully, we see a lot of patients who can tolerate the therapy when it's given back, even when they first had a toxicity. And sometimes they do not have that same toxicity. They might get others, but sometimes they don't even get that same toxicity. So absolutely, durable responses are possible if you've just had a few doses, and there's always the possibility of having more therapy in the future with a good discussion always between you and your team.
Great. Well, I apologize. This is a short time frame to talk about all the exciting changes in the world of melanoma, but we are really privileged to give this talk, and Happy New Year's to everyone, and so thrilled to see over 100 attendees on a Monday afternoon after the weekend. So I want to thank AIM at Melanoma for allowing us and inviting us. We love doing this, and we love sharing our passion about melanoma and all of the amazing things that are going on. If any of our questions weren't answered, you can, in the chat on the bottom of your screen is contact for the medical expert at AIM at Melanoma that you can submit your questions to. Or you can reach out to either of us through online mechanisms if you need to. So I want to thank everyone for coming, and I hope that feel like it was a lively discussion. So, and thank you all for your questions and interest in helping to change the way we think about melanoma. So thank you.
And without belaboring, I'm going to say thank you too. Jeff has said all the right words. I really appreciate your attendance here, and have a great day.